Thank you so much. So we are coming up at the end of this session with a lot of important messages, I think. And I think I wanted to mention that when we were structuring this session, and in the early discussions of the pediatric days of this year, we were saying, well, we always do neonatal care, and we have done KMC and zero separation and breastfeeding in previous years. So why should we repeat this? And actually, we believe that the expertise are there, the evidence-based knowledge is there, but there is something happening in the translation of implementation that we're not yet achieving. So that's why we brought this subject again. So we would like to start the panel discussion, and please feel free to intervene with a first overarching question. So we saw this these three key moments in the continuum of care of a pregnant woman and her child. And our first question would be, how can MSF or other organizations, or how can we partner even with other organizations to ensure that we are changing this paradigm that maternal and newborn care are actually completely connected, inseparable, and that we should be taking care of both throughout the continuum of care. So if anybody wants to go ahead, Claire, I see you smiling and nodding, so I'm guessing you want to go ahead.
So I can begin. What I think is very important is that first, you all know all this, but there is a lot of people within MSF who doesn't know the benefit of this initiative. Breastfeeding, zero separation, skin to skin. So I think we have the role also to be very pedagogic, if I can say, to make some kind of publication, communication, explaining to people that it's not just a question of well-being, which is something very important also because we want, and at the institutional level of MSF, we really want to reinforce patient-centered approach, involvement of patient, mothers, and etc., but that there is the clinical benefit. And I'm not sure that this is really known within the organization. So this is the role of let's say, the medical community. And the second point is really to help and discuss and work with the operation to see how we can do it. Because sometimes when we arrive with a new initiative, new things, it seems complicated to everybody, especially if you don't know how it works. And the third thing is that the experience of other partners, I think, is really key. And this has to be also discussed and shown in our organization.
Thanks, Claire. Yeah, would you like to go ahead? Yeah.
I just want to start by saying that this is not just unique to MSF or to working in crisis. I mean, the average time to translate research into clinical practice in the UK is 17 years. So this is not unique, and you shouldn't be harsh on yourselves, and you work in extremely challenging conditions. If I may share our experience in GINA was mainly based on quality improvement science, just doing short cycles of PDSA, Plan, Do, Study, Act. So if things didn't work, we changed them the next week. I understand now, as we are growing bigger, that this might be difficult, but having a combination of the big organization approach that provides stability, but the small organization, agile, quality-centered approach might be the answer. As well, most of our staff are very young, freshly graduate nurses and doctors and midwives. It's so much easy to convince those enthusiastic youngsters to do more work and to do it in an innovative way. I've learned so much from them, actually. I take it back in my practice as an emergency physician. They have the capacity to deal more with the now and then. They're embedded in the community, and they've got a lot of energy. And how they introduce change, how they translate that into action, seems to be much more successful than anything I could come up with. So I think it's this combination of being quality-centered approach and utilizing untapped resources within the same community. from the freshly graduate midwives and other healthcare workers. Thank you.
Thank you so much for those insights. I just want to sort of like come back to the focus of, yes, we're preaching to the choir. This is a room full of nurses, pediatricians, midwives, people who have all this experience in this field. So it doesn't come up as a surprise what we have presented. But the problem is people in operations, people with the budget, people with the money to make things happen, sometimes they don't have a medical background. So what Claire was mentioning, I think this link between the technical expertise and the people holding the budget needs to be better addressed. And then, of course, the quality improvement cycles that we should be going through. But as you mentioned, as we become a monster of an organization, it seems more and more difficult. But empowering the teams at project level, that would be an amazing tool for us to make these things happen. I don't know if there's any other comments from the... Yes, Maria? Sorry. So you know... sorry. I didn't introduce you properly. I'm very sorry for that. So you heard Rim through the presentation of Gina. We have Claire Rieu, who is our medical director for MSF France. We have Maria Trevisono, who is the health advisor for MSF Spain. We also have Dyad, who works with MEHAT, and you heard his presentation earlier, and Melissa Hodgson, also a neonatal nurse working with MSF France. Sorry, Maria, go ahead.
Thank you very much. So to answer to your question, to complement what Claire and Rim said regarding how we can make it operational at our level in our context, today and yesterday we have seen a lot of ideas. We are really inspired, and I wish that we will continue to discuss, to brainstorm, and to bring action in our interventions wherever in the world, because if we focus on the benefits of the Dyads, which is a life-saving strategy, it can be cost-effective, and there is no need to involve millions of budget in our intervention. So we can be simple, transformational, and we can bring benefits in the community. We need to shift our mindset from health system approach towards a much more patient and family-centered approach, bringing attention to the dyad, mother and baby, but also in the future to the triad. Thank you.
Thank you so much, Maria. And I would like to go back, because of this continuum of care, to something that Princess Sarah Ziad mentioned this morning, how we seem to sort of like dismember the care of these women that come to our facilities, right? So one of the NGOs is taking care of this part, and another NGO is taking care of that part, but nobody seems to be seeing the whole picture, right? That's where we're not being very well. So I guess, but because I really want us to leave from this panel with some clear recommendations, how would we tackle this? So I let you reflect on that as we go on through the next questions. But we would like to really come up with some clear recommendations at the end on how to partner with people that are doing things outside of MSF, so that we can capture the whole continuum of care. So now I'm just going to talk to you a little bit about the results of our Mentimeter earlier that we did with all of you. And we're going to start with the first subject. So if you remember, the first subject was screening mothers for risk factors that can then impact the outcomes for them and their babies. And we started with maternal MUAC screening, and we also mentioned anemia screening. Well, the results that we had was like, most of the people in the room felt that MUAC screening was mainly implemented in ANC care. But we are not screening mothers when they come to our ITFCs. We are not screening mothers when they are coming to other wards or services. We're not screening mothers anywhere else, really. And most of our projects do not have ANC activities. So that is a reflection to have in mind. And the main barriers for implementing this were, one of them was, we don't treat pregnant women. So the projects who don't treat pregnant women feel like it is not my thing to take care of, right? So how can we integrate this into the care? There seems to be not a lot of clear guidelines. People do not know that there are guidelines to MUAC screening during pregnancy. And of course, if there are no guidelines and there are no protocols in place, then we also don't have the supply for the treatment or even for the MUAC bands. So and this is a question directed to Meha. Sorry, I'm getting lost here. So after hearing about the experiences of MSF, do you think Mehad has found similar challenges in implementing this MUAC and anemia screening? And what can we learn from you, from your experience?
I will answer according to the Syrian context. The main barriers for MUAC screening is it's not implemented at all levels of healthcare and all healthcare providers. In the private sector, MUAC screening is not performed at all. Also, in the public sector, because there is no overseeing body that or unified protocols for all the healthcare providers to implement the MUAC. So it is each health entity or each health organization, they have their own protocol, while this is not implemented for other organizations or in public hospitals or other healthcare providers.
Thank you so much. I don't know if there are any reflections from our people from MSF about this implementation in the room. Here.
I have just a question. What about giving the MUAC to the woman and she can monitor herself? I think you have also a community level action. So what is your opinion about that? Do you think it can help?
Yes, it's one of the main problems in implementing MUAC is the lack of health awareness. Most of our patients, if they don't have symptoms or severe symptoms, they will not seek health care at all. So this is maybe a good idea to implement, but I'm not sure if this will be implemented or will be acceptable by the population.
That is a really interesting comment, because one of the recurrent comments that we got from the Mentimeter earlier were, we don't have malnourished women, we don't have malnourished pregnant women. And I think we do have, we just don't screen them, so we don't know them. Thank you so much for that. We will go to the second main key topic that we talked about during our continuum of care, which would be monitoring and preparation for delivery at maternity level. So this is a question in general for all of you. In contexts where we have a high turnover of staff, how do we keep our staff trained to respond to these really essential and emergency moments like delivery and birth? And this is what was reflected in the video from Afghanistan, from our team in Host, where they have developed this calendar of trainings. But we know that this has been very challenging when we have teams that are constantly changing over and over again. So I would love to hear from your experiences and also what our operational people think. So somebody wants to go ahead? Melissa, I see you smiling.
I think we've heard a lot of really good examples today of what can work, and certainly we do see a high turnover of staff in a lot of our projects for many reasons. And I think it comes back again to time. How are we onboarding our staff with the skills that they need, the knowledge they need, the time that they need to have that onboarding? How are we following up with a learning and development pathway, looking beyond a specific training, but a pathway for learning and development? We can pass on all the knowledge that we can, but we also have to equip the teams with the skills and the resources to be able to carry out that evidence-based care. And learning is not one-off, it's a continuum, and so we need to have that strategy in place and be able to individualize each person's needs.
Thank you. Anyone else from the panel with that? No? Rim.
I mean, what we used is a virtual means to continue the training. So time is scarce. That's time is a commodity. So when we have one educational event that is shared moment, not necessarily an event. With this case, I dealt with this case and it was difficult. And you've got this secure channel that helps everybody to learn from it. And learning as well for the patients or the audience, especially when it comes to maternal care. There is a need. Mums go to Instagram and internet and they get wrong information. So actually, it helps when the mother knows what should happen because she asks for it. So maybe, so that I don't take too much time, I think using virtual training, engaging, not just passive, there is a material, look at it when you've got the time. It will help, and engaging the patient group or the mothers and the fathers would definitely help that a lot of these protocols to happen again. And simulation and briefs after major events. So after a resuscitation, let have 5 minutes of a brief. It comes back to the time. So it's multifaceted, and we will not always get it right, but the more facets we have, hopefully the more we get it right. Thank you.
Thank you for that. And yeah, I think in MSF we could do quite a lot to ensure that patients actually know what good care looks like so that they can demand it, right? Just wanted to give you also what the Mentimeter said. So we got about half of, like, from all the people that answered, they felt halfway like we were doing this monitoring during labor. So not strongly agree, not strongly disagree, always kind of in the middle. Are we doing partographs? Are we assessing for risk factors? Are we having everything ready to resuscitate a baby? So everything was kind of like not great. And the main barrier for that was basically workload. So this is what we hear again and again and again, and I think it's something that we really need to reinforce also in MSF, and I would love to hear whether Claire or Melissa would like to comment on this, but is that we always have this very stretched, thinned out staff for a number of deliveries, for number of beds, for number of patients, for number of babies. And just reflecting on what Melissa was saying earlier, how much time does it take for a nurse to support breastfeeding, to take care of a mom? How much time does it take for midwives to monitor a baby? And so we need to be coherent with what we're asking from our staff, I think. So Claire or Melissa, if you would like to comment on this HR ratios and workload.
Yes, this is one of the most difficult questions. So in MSF, we have workload, but sometimes no. So I think it's very important in the project where the workload is important, but not so important that we can put in place all these activities. And also to be, let's say, pragmatic. When it's too much, it's too much. And so, but to make sure that all the caregiver or the nurses, doctors, they can know by themselves what is the most important, the most urgent. Because sometimes we give so much and so many things to do. We have heard about all the competing priorities that sometimes they don't know how to choose. So what I will say, the common sense, le bon sens, I don't know if it's clear in English, has to say, and I will make also what we are all fighting for, to have good doctors, good nurses with good clinical reasoning and making this. The second thing is maybe in this kind of initiative, it's a way of organization, and maybe the organization will cover a part of the workload. What I mean is that if we organize the care with the mother and the baby, of course, we have to organize the HR to make sure that they will see, but maybe it will be simpler in the pathway of the patient, the transmission of information. So we have to work on these two sides.
I think as well, I gave the example of the time that it takes to feed one neonate and to support the mother. That's every 2 to 3 hours. And imagine one nurse has 10 babies, 10 mothers, and every 2 to 3 hours they have to support the feeding, but also administer the prescribed medications. This is a lot harder than you may realize when our medications are actually adult strength dosages, and it's quite complex for nurses to safely often double dilute, make sure they have the right equipment, make sure that we're doing this safely. This all is about patient safety, but it does take a lot of time. So we have to consider, what are we looking at? What are we aiming for a minimum standard to ensure that we are delivering a quality of care, while also being able to enable the nurses and the doctors and all of our colleagues to be able to spend that time with the mother and to speak to that mother and ensure we are integrating family-centered care and zero separation and supporting skin to skin. It really does take a lot of time. So I think that has to be acknowledged as well when we consider HR workload.
Thank you, Melissa. So we will go to the last subject of this session, which was basically zero separation. Just to comment on the Mentimeter results again. So most of you in your projects felt like mom and baby were being kept together in the first hour of life and were breastfeeding. But I think the problem comes to if there is a complication during the delivery, or if there is a C-section, then most of you felt that mother and baby were being separated for sure. Most of you said there are no beds for mothers in your projects. So most of your projects have neonatal care units that only include baby cots, like we saw in many of our videos. But most of you did feel that in postnatal care, mother and baby were checked together. So when they do come back to us, we do see them together. So there are certain areas of zero separation that might be working a little bit better than others. And this also gives us some insights on where do we need to put the accents and the actions. And the main barrier, the main perceived barrier for implementing zero separation was space. So I think most of you thought, oh, my neonatal ward is like 2 square meters, where am I going to put the mothers, right? Looking at these results and these comments, I just want to recognize again the amazing work, for example, that Mehed and Gina have been doing in places where war has disrupted everything, and you have been successful in implementing stuff. So I think we need to think that this is still possible wherever we are working. Maria, since you are our ops representative here today, I would love to hear from you. What needs to happen for operations to embrace zero separation approach across all projects with maternal and newborn activities? Complicated question, but...
Okay. It's not an easy question, it's true, and there is no perfect answer and there is no unique answer to this question, because it depends on the context, it depends on how the community is perceiving the zero separation as well, and how we can put this in practice and our modus operandi, meaning if we have a standalone facility or if we collaborate with other actors as well, including MOH. In one of the presentations, we spoke about the stubborn elephant, which can be one of the challenges that we face. If we think about the facilities where we operate, we often have this clear separation between maternity and neonatology, newborn unit. Sometimes newborn unit is on the other side of the maternity, so it is not even easy to reach the newborn, even for the mothers, for the postpartum, and especially for the post-C-section. We have seen options even during these days of conversation and presentations. We have seen that we can include the fathers, we can include the family members in newborn care whenever for the mother it is not possible. And we need to ensure by supporting the teams in the field to focus on what is essential, because it's true, one of the challenges, the workload. I cannot forget when I was as well in the field as midwife, how tough it was to ensure proper care for everybody, and sometimes it was just not possible. This means that we need adequate resources, We need to negotiate and advocate at MOH level, at partners levels as well, putting our efforts together to improve the situation. Sometimes it is not possible to change the space. We have to be realistic on this as well. Sometimes we cannot build another building or change completely the structure of the facility, but it is important to think out of the box and focus on our objective. If our objective is to reinforce the dyad mother and newborn, we can do little things as well, starting in a gradual and stepwise approach. We have seen that with the colostrum, we can ensure access to colostrum for the newborns. We can engage the family, and gradually we can change the mindset, and we can at least try, and it takes time, to change also the space issue. Sometimes also we have the resources already in the projects, but we don't identify them. So just let's be curious about what we have, let's be critical about what is already in place, and we can make it happen. It is possible, it is doable, and we all have the responsibility to make it happen. So there is framework, there is material available to make life easier in the field as well. There are references, there is a huge teamwork around everybody, so no one is alone in this, and we can work on it together. Thank you.
Thank you, Maria. We're coming at the end of this session, and as I said in the beginning, I want to leave with very concrete actions to recommend to people. So I would love if each of the panelists could give a final recommendation, something concrete. I'm thinking of, okay, the next time I am discussing about this subject with an operational people, with the people holding the budget, how do I get this to work? So I let you reflect a little bit, and if you guys have an answer, really concrete actions, we would love to hear them. I see Rim is ready.
Sitting in the meeting with management, I would say I have a cost-efficient, highly effective, low-cost interventions, and these are the lists. And I would put the using technology virtual. Don't need to have a sophisticated app, but use technology, because mothers in most conflict zones, if they can access it in Gaza, I think they can access it elsewhere. Why can't we use that? But it needs someone to moderate these. But that would be one person equivalent to 3,000, 4,000 women. So tap into the readily available virtual means, but it has to be safe. Okay, it has to be moderated. The second thing, invest in the newly graduate members of the community. They are really, they're the movers and the shakers in our group. And I don't think that is well utilized. And they're not necessarily looking for high salaries. They need to have a decent salary. But you might be hiring 5 for a senior nurse or a senior person salary. But you have to invest in their training and education. And that would actually help in creating time for training and education. So these would be my 2 recommendations, is let's invest in using technology, and let's invest in fresh graduates who don't have anything on their CV. Those people, when they apply for jobs, they're filtered out.
Thank you, Rim. Taha, would you like to go ahead with your recommendation?
Okay, I will emphasize first as she said that the gradual improvement. As a little better than nothing. I will give an example. 3 years ago, most of our midwives, they didn't know or they didn't hear about what is partograph. Maybe they feel it as an MRI or as a big device, and then they discover that it is a one paper. And now we have 100% implementation of partograph in all of our facilities. So this is started with training, with awareness about the importance of using simple tools. Also utilizing simple tools is very effective, especially in context with low resource setting. In addition, also the capacity building is a very effective component in improving healthcare. And my third recommendation is that to maintain or to ensure the minimum standard. And it's better not to provide the services lower than the minimum standards. Thank you.
Thank you for mentioning the minimal standards of care. I think this resonates with MSF. Maria, do you want to go ahead with your recommendation?
Yes, okay. So, is it working? Yes, okay. So, from my side, in addition to what our colleague says, I would recommend to have simple and effective and transformational actions. And my recommendation is also to share information from our level as well, and to reinforce the teamwork among us, all of us, and with other actors as well, via partnership, and as well to learn from each other, because we have so many experiences, we have so much knowledge around it, and if we share information, if we share knowledge, we can improve for the patients, for the family, and for our partners. Thank you.
Thank you, Maria. Melissa, and then Claire, if you can close.
I think we all have a responsibility now. As Claire mentioned, not everybody might not be aware of what we're talking about today, but now we are. So we all come from different backgrounds, different roles, and we all have a responsibility of how we can integrate what we've talked about today and yesterday and during all of Pete's days into our day-to-day work. And also I would say let's not be afraid of change and the way that we think. Change takes time, but it's changing the way we think about how to do this approach. What can we do when we open a new project versus what can we do now in each project to meet those individual needs that often doesn't require a lot of additional resources, but there's certainly different strategies that we can look at into each project now to help supporting each project now.
Thank you. Go ahead, Claire.
So I think I will take my ops colleagues, then we will go to a place where it works to show, and especially to Gina or Mead place, and then make partnership and open our eyes and our mind and go further.
Thank you so much, Claire. So as take-home messages, I would say we need to make kind of like this link with operations, so that operations, who is not the non-medical people, they know about these subjects, because many of them have never heard about it. That we do need to take from the resources that are already existing and shifting them to working into the very essentials, like breastfeeding, like KMC, like zero separation. We don't need to put tons of money into things. Investing in gradual sort of growth from our staff, capacity building, making sure that there is this continuum of training, of skills acquiring, and mainly keep the discussions ongoing and do not shut up about neonatal care. Thank you, everybody, and thank you for the panelists.